on to our next session, I would like to introduce our chairpersons, Dr. Ashok Kumar Gruber, Dr. Pradeep Sharma, and Dr. Ramesha Kekunia. I request all the chairpersons to please unmute themselves and switch on the camera. Over to the chairperson. Thank you.
Dr. Pradeep sir and Dr. Ramesh sir will be joining us in a while. Over to you, Ashok sir.
Thank you. Welcome to this session of EyeShala, and all kudos to the team that has designed this, because I see a wonderful program and I'm sure the postgraduates are going to enjoy it. Just an aside, this started, the postgraduate teaching program at All India Ophthalmic Society started 10 years ago. This is the 10th anniversary. That was during the year when I was the president when we started this program. And from then on, it has taken a huge momentum. The postgraduate teaching programs for the zones were also started in the same year, 2011. So that also is 10 years now. So I'm sure you're all enjoying it. It has made a huge difference to the awareness of the postgraduates, and I'm sure these programs will continue to do so. The feedback from postgraduates about these programs will be vital so that these can be modulated accordingly. So look forward to the first talk. Hand over to you.
So the first talk for this session is by Dr. Raksharao. You're requested to please share your screen. Her talk is on the pearls in the interpretation of CT scan and MRI. Dr. Raksharao is a consultant in oculoplasty and ocular oncology at Narayana Nethralaya, and she has done her fellowship with Dr. Santosh Anavasa and followed by her training under Dr. Jerry Shields and Dr. Carol Shields at Wills Eye Hospital. Over to you, ma'am. I believe your screen is frozen. Raksha ma'am, am I audible?
I guess Dr. Raksha is having some technical glitch from her end. I request the chairpersons to move on the next speaker, and we will follow up the speaker once we have a good connection with her.
Okay, Tanvi, from your end, could you please stop screen share? Yeah, thank you so much. So would you like to move on to Maya Hara, ma'am? Ma'am, are you there?
Yes, I'm here. Yes.
Yes, ma'am.
Welcome, Maya.
Yeah. Hello, sir. Okay.
So, ma'am, would you like to take a session, ma'am?
Yeah, sure, sure.
Great. Okay. So, ma'am is a consultant at SMS Hospital, Jaipur and Rajasthan, and she's done her fellowship at LBPI in ocular oncology and oculoplasty. Over to you, ma'am.
Okay, thank you, Rolika. So I'm going to deal with the oculoplastic X files, and here I'll be taking you through some long and short cases which are for your PG exams. So first, we'll go through some case scenarios of ptosis. This is the first case, 4-year-old male who is having moderate ptosis with the faint or absent lid crease and a poor LPS action. Here is the second case with the 64-year-old male. He is having a severe ptosis with high and deep lid crease and a good LPS action. Here is the third scenario where a patient having severe bilateral ptosis with epicanthus inversus and shortened palpebral aperture with a family history positive. So these are a few important case scenarios that you can get as a long case, and we'll discuss the features and the examination of these cases in detail now on. So whenever you get a case of ptosis, first of all, you should classify it whether it is congenital in onset or acquired. Then etiologically, whether it is myogenic, neurogenic, aponeurotic, or a mechanical ptosis. First and foremost, rule out pseudotosis. You may get a case of a vertical squint, like in this case of hypotropia of the left eye. When the patient is fixing with the right eye, there is an apparent ptosis in the left eye, but as soon as the patient starts fixing with the left eye, then the ptosis disappears and the other eye goes up. So rule out a vertical squint or a hypotropia in that eye. This is the whole proforma of the ptosis workup, and let's see them one by one. What is the importance of doing a visual acuity or pupillary assessment in a case of ptosis? So to rule out any amblyopia, which can be most likely an anisometropic amblyopia due to refractive error, or a pupillary involvement can be there in a neurogenic ptosis like a Horner syndrome or a third nerve palsy. You have to do a visual acuity and pupillary assessment. Then check for any abnormal head posture, like bilateral severe ptosis can have some chin up positions. Look for the position of the eyebrow, like frontalis overaction may be evident in cases of unilateral severe ptosis. Check for the lid crease. So lid crease is important to differentiate between the congenital and acquired ptosis. Like in congenital ptosis, you may have a faint or absent lid crease, while in acquired aponeurotic ptosis, it will be high and deep. Look for the margin to reflex distance. There are 3 MRDs, 1, 2, and 3. You have to measure the MRD 1, that is from the upper lid margin to the corneal light reflex. That will give you an amount of ptosis. MRD2 is from the lower lid margin to the corneal light reflex. That you can also mention in your ptosis workup. MRD3 you don't have to mention. I'm sorry. So depending upon the amount of ptosis, it can be divided into mild, moderate, and severe categories. Always look for a compensatory lid retraction in the other eye. And this may be there in a case of a severe unilateral ptosis because of the Herring's law of equal innervation. The other eye may go up, and as soon as you close or lift up the involved eye, this compensatory lid retraction will disappear. LPS excursion is measured by putting the scale in the patient looking in the extreme down gaze, and then ask him to look into the extreme up gaze, and whole of the procedure is done by blocking the frontalis. You have to block it with your thumb and then do the LPS action measurement. So it can be classified as good, fair, and poor. Poor we say when it is less than 4 mm, fair is 5 to 7 mm, and more than 8 mm is a good LPS action. This is called as a Burki's method. In infants or children who are not cooperative for this Burki's method, you can just do an ELIF test. So evert the upper eyelid, and as the child looks down, it will revert back on its own spontaneously if the LPS action is good. Also, indirectly, you can assess it by checking the lid crease. If it is a prominent lid crease, then it means that the LPS action is good. Vertical tarsal height you can measure in cases of mild ptosis where you are planning for a Fasanella servant surgery. Always look for lid lag. That is, when you ask the patient to look down, check for the movement of the eyelid, whether it is following the eyeball or not. So lid lag is a very characteristic feature of a congenital ptosis. Bell's phenomena is important when you are planning the surgery, and you have to always grade it, that whether it is a good Bell's, fair Bell's, and poor Bell's. So if you are seeing less than 1/3 of the cornea when the patient is closing the eyeball, then it is called as good Bell's. Poor is when more than half of the cornea is visible. Reverse Bell is upward and inward rolling of the eyeball, and inverse is downward and inward rolling of the eyeball. Always ask the patient to move the jaw and check for any synkinetic movement of the eyelid, that is called as Marcus Gunn jaw winking ptosis. Now it's very important to look for the ocular movements. Like in this case, when you ask the patient to look up in abducted eye, this eye is going up, but this is not. So this is suggestive of an underaction of the superior rectus muscle. So this happens usually in double elevator palsies. Always do a workup for dry eye by doing a tear film evaluation and check for corneal sensation. Whenever in doubt for an acquired ptosis, check for old photographs. You must do some important tests whenever required, like IcePack test in myasthenia gravis and phenylephrine test when you have a mild ptosis. Coming to the next long case, that is proptosis. First case scenario, it's a 45-year-old male who is having a bilateral axial proptosis, periorbital edema, and restricted ocular motility. There is lateral flare, and on imaging, you can see enlarged belly with the sparing of tendons. So this is a sure case of a thyroid ophthalmopathy, and in the workup, you must include all the lid signs. There are 25, but at least 10 you should know and do include in your workup. That is lid retraction, lid lag in down gaze, absence of forehead crease in up gaze, etc. To check for any activity in the thyroid eye disease, look for any congestion near the insertion of recti muscles. Do a retropulsion test. If you found any resistance to retropulsion, then it's called as positive retropulsion test. To rule out any restrictive myopathy, check for ocular movements, and always do a systemic examination to check for any neck swelling and check for fine tremors that can be associated in hyperthyroidism. Now, you can get a case of a plexiform neurofibroma like this case, and they may have an S-shaped eyelid associated with the ipsilateral facial asymmetry. There may be a dysplastic sphenoid, greater wing of the sphenoid, which can lead to a transmitted pulsation causing a pulsatile proptosis. Always do a detailed systemic examination. Here you can see cafe au lait spots, subcutaneous nodules. These may be associated with plexiform neurofibroma. If you get a case of an adult who is complaining of pulsatile proptosis after head injury, and on examination you saw the dilated episcleral veins, that is the corkscrew vessels, and increased intraocular pressure associated with the radiographic finding of dilated superior ophthalmic vein. So this is a case of a caroticocavernous fistula. In case of a positional or intermittent proptosis, like this patient complaining of proptosis only on bending forward, which resolves on lying supine. So you have to measure the proptosis by performing a Valsalva maneuver in such cases, and these are usually caused by orbital varices. Now, if you get a case of proptosis, which is abaxial in nature, and the mass is located in the lacrimal gland fossa, you have to look for some important signs, like if there is any tenderness or bony margin irregularity. If it is associated with signs of inflammation, tenderness, and irregularity of the bony ring, it is likely to be adenoid cystic carcinoma, or in the other case, it can be a pleomorphic adenoma in absence of all these features. If you have a case of a child with axial proptosis and vision loss, you must rule out optic nerve glioma. While optic nerve meningioma will present in slightly later age, and here the proptosis will appear first and it will be followed by vision loss. And characteristic radiographic finding you must know is a tram track appearance in meningioma and a fusiform appearance in optic nerve glioma. Now do some important examination tests in the OPD, like worm's view. That is, when you look from downwards, you can see the difference between the apex of the cornea of the two eyes. The proptotic eye will appear more prominent, while the Navziger's view or the bird's eye view, the examiner have to stand behind the patient and look from above downwards. Here, normally you don't see the eyeball or the apex of the cornea because of the prominent supraorbital rim. In case of proptosis, it will appear prominent. And how to measure the proptosis? It is by most common method is the Hertel's exophthalmometer. So you put the Hertel's exophthalmometer on the lateral orbital rim and measure the distance from here to the apex of cornea, and always keep the base constant for subsequent reading for comparison. Other exophthalmometers name you should be aware of is Lude's exophthalmometer, where the notch is placed on the lateral orbital rim. If the lateral orbital rim is not intact, you must know about Nogle's exophthalmometer, which can be placed over the superior and inferior rim. Now, another method is a radiographic method, where you draw an imaginary line onto the interzygomatic plane. Interzygomatic line is drawn in the mid-axial CT scan, and you draw two perpendiculars from the apex of the cornea falling onto this line and measure the proptosis. Whenever there is a case of abaxial proptosis, always measure dystropia by two-ruler method. And here you measure the distance from the center of the nose to the center of the pupil. Always rule out pseudoproptosis in cases of ipsilateral eyelid retraction, contralateral inophthalmos, ipsilateral biophthalmos or high myopia, or cases of shallow orbits in craniosynostosis. So whenever you get a case of axial proptosis, it's likely to be either thyroid or intraconal lesion. Whenever you get abaxial proptosis, it's likely to be an extraconal lesion. And depending upon the location of the tumor, the dystropia occurs in the opposite direction. Like if the patient is having subperiosteal hematoma, it will be downward dystropia. The patient is having ethmoid tumor or ethmoid mucocele, it will be lateral or horizontal dystropia. Examiner may ask you the differentials for unilateral proptosis, which is acute in onset in a child. So remember, if it is associated with fever, URTI, sinusitis, it's likely to be cellulitis. If it is associated with history of trauma, likely to be hematoma. If there is an increase in proptosis with the URTI, and it can be a sudden expansion or chocolate cyst formation in the lymphangioma. If the general condition of the child is poor, anemic, he is lethargic, and there is a rapidly progressive proptosis, it could be a leukemic infiltrate. So leukemic infiltrate or systemic metastasis, systemic malignancy will give rise to eventually a bilateral proptosis. So coming on to some short cases. This Dr. Feroz has already discussed. I will not go into the details. This is an upper lid sebaceous gland carcinoma, and this is a lower lid basal cell carcinoma, rodent ulcer. So the third case, this is a lady presenting with watering and foreign body sensation. And here you can see that the lid margin is inverted and the lashes are rubbing onto the cornea. So this is a lower lid senile entropion. Here you have to do certain tests like assessment of the medial canthal laxity by pulling the lid laterally. And if the punctum is pulled till the medial limbus, it is called as lax medial canthus. Lateral canthus laxity, it can be depicted by rounding of the lateral canthus and pulling of the lateral canthus till the lateral limbus. Then you have to judge the orbicularis muscle tone by snapback test. Usually when you pull the lid, it will go immediately back within a one blink. If it is taking time, like one or more blink, then it's said that the muscle tone is lax. Distraction test, if you can pinch the lid away from the globe by more than 8 mm, it is said to be positive. Then you have to differentiate between senile and cicatricial entropions. In cicatricial entropion, it will be involving mostly the upper eyelid with the thickening of the tarsus, and there will be signs of cicatrization like conjunctivalization of cornea will be there, severe dry eye will be there, metaplastic eyelashes will be there. Then coming to ectropion, it may be again a senile or cicatricial ectropion. Senile ectropion will have similar characteristic as I described for the senile entropion. Here there is a history of trauma followed by scarring of the lower eyelid, which is pulling the eyelid downward. So this is a case of a cicatricial ectropion. Now paralytic ectropion may follow a facial nerve palsy. Here you have to look for the absence of forehead wrinkles, then incomplete closure of the eyelid, then deviation of the angle of mouth. So all these features favors a facial nerve palsy. In case of a watering with presence of erythema and swelling just below the medial canthal region, this is a case of most likely an acute dacryocystitis due to chronic nasolacrimal duct obstruction. And to check for the nasolacrimal duct obstruction, the test you have to perform in OPD is the Roplas. And if you get a clear mucoid or mucopurulent regurgitant on Roplas test, it is diagnostic of an LDO. In case if you don't get Roplas positive and there is a cystic swelling that does not disappear on pressure over the lacrimal sac region, then this is suggestive of ancystic mucocele. That can also come as a short case.
With all due to respect, I request Dr. Maya to please wrap up the session.
Right. So this is the last case. Okay, this is the last case. So
yes, ma'am, please sum up within 30 minutes.
Fine. So this you can get a contracted socket case also, and you have to do a complete socket workup by measurement of the depth of the fornices and volume of the socket, and label it as according to the Gopal Krishna classification. Thank you very much.
Thank you so much, Dr. Maya, for such an informative session. I would request the moderator, our chairpersons, to please invite our next speaker. Thank you so much.
Ashok sir, is it okay? We'll continue with Raksha ma'am,
Correct. Yeah.
right? Okay, Raksha ma'am. Please go ahead and share your screen, ma'am.
Yeah, sorry for the blip earlier.
Yeah,
Okay.
it's, yeah.
Is it fine now?
Ma'am, I think there is still some connection issue because your voice is broken.
Fine, right? Okay. So for CT and MRI of orbit is indicated
Raksha, we
when
still can't hear you. I think we'll have to do something about your connectivity, Raksha. Can't hear you, Raksha.
Apologizing, Dr. Raksha. I would like to connect you to our AV team, and if you don't mind, can I just can we just move on to the next speaker and
डॉक्टर रक्षा
just
अपने अपना कैमरा ऑफ कर लीजिए मैम.
Yeah, if you can switch off your camera, then automatically it will. I think she's already done that.
chairpersons, would you like to go for the next speaker, and we can connect her to our AV team so she can connect her with us in a very good way with
Sure.
a good connectivity?
We can have her as the next speaker.
Yeah.
Yeah. Thank you so much. Yeah.
We'll go ahead with Savi Desai, ma'am.
Good afternoon, everyone.
Good afternoon, ma'am. Hi, ma'am. Dr. Savi Desai has done her fellowship in ocular oncology and oculoplasty at LVPI. And ma'am, would you like to share your screen?
Yes.
Her topic for the day is common oculoplasty surgeries. It's a video assisted presentation.
Thank you, Rolika, and please do keep the timer on. Though my thing is exactly 14 minutes and 30 seconds.
Perfect, ma'am. So we can go ahead, ma'am.
Good afternoon, everyone. I will be speaking on common oculoplasty surgeries, and good afternoon, Dr. Grover, and thank you to the entire AOS team to be part of EyeShala. So we're going to be dealing with 4 topics: back to basics, timing is everything, less is more, and mending the broken. So in back to basics, we'll be talking about eyelid margin repair. And the reason I've chosen this is because this versatile pentagon excision, along with a repair of the eyelid margin, is not just useful for eyelid traumas, but is useful for many conditions such as notched eyelids, trichiatic lashes, even cases where you want to take a small biopsy or which is full thickness. And this versatile pentagon lid excision, along with a good opposition of the margins, is something that I think we all should absolutely master. This gentleman was a 50-year-old man who had an interning or a notched eyelid. So I've marked out the pentagon excision, marking the eyelid crease and making the vertical cuts after keeping the eyelid at a stretch on both the sides. And then the triangle has to be matched. So you have to be sure that it is not short or below the eyelid crease or way above the eyelid crease, and that will either end up giving a notch or an entropion. Absolutely perpendicular cut should be made to the eyelid margin, as is seen here on both the sides. So I prefer to use just blades instead of RF cauteries for these kind of surgeries because I feel the incision is cleaner. Using a straight scissors, you make a bold straight cut involving the vertical portion of the pentagon lid excision. Similarly on the other side. And this is an important point where the diagonal portions or the pentagon portion should be cut not at an angle so as not to cause a slant. And this is especially important in cases where you have a biopsy. Now, this is the vertical mattress suture, which is really important. And it basically follows the principle far, far, near, near. Something to remember is 5 millimeters, 3 3. So far. So you start here, as you can see, go through the meibomian gland orifice, come out through the tarsus so as to give it a far more better structured hold. So this is approximately 5 millimeters. Similarly, you go on to the opposite side, which is approximately 5 millimeters, through the tarsus again, and out through the meibomian gland orifices. The gray line, which is a kind of a line which is between the anterior posterior lamellar, does not have any significant structure. So it is better to pass it through the tarsus to get a proper apposition as well as to prevent it from interning. Once you've done the far part of the suture, you want to go in and do the near, so approximately 3 millimeters away, and then again coming out through the tarsus, you bring out the suture. And similarly on the opposite side, and bring it close together. So you should have a slightly pouting appearance, or the famous pouting eyelid that we know, and suture the eyelid. This basically is your eyelid margin suture. See that you remove any interned eyelashes. That's a very tiny step, but it's important. And once you do this, before you close in layers, there's something a little small that I like to do, which is take the eyelash suture line and match it so as to release the tension and the pressure which is being held on the eyelid vertical mattress suture. This also helps in opposing the lashes well, so you get a good cosmesis. Especially in patients who are younger, this is very clearly seen. So I do take this line. Then you take a partial and not a full, a partial thickness tarsal bite. A full thickness was called is it irritation on the cornea. So we want to be sure, using 6-0 Vicryl, and you tie them. I use 6-0 Mersilk for the vertical mattress suture. So approximately 3 to 4 depending on your defect. Then you close the orbicularis. Now it's a very vascular muscle, so you really don't need to take a lot, just take a little bit and it opposes and heals beautifully. Followed by the skin sutures. The skin sutures are opposed with, again, 6-0 Mersilk. So stretch the wound. If you've taken a good pentagon excision, you should not have what we call a little bit of a dog ear at the end. But if you do, you need to trim it, and that's at the tip of the upper part of the pentagon excision. And at the end, I like to turn over the long vertical ends of the vertical mattress suture and bring them into this, so it's tucked away nicely away from the cornea. So this was just the basic part of the eyelid. Coming to, from eyelid, we go to eyelid, which is ptosis, where timing is everything. This is a young 2-year-old girl who had a ptosis, which was moderate to severe with a slight Marcus gun phenomena. And this is a ptosis surgery, which is done using Ethibond. So Ethibond comes, ideally you need to use it either in 3-0 or 4-0. So ideally if the child is less than a year, you need to use year or 2 years, it's 4-0, otherwise you can use 3-0. Also a lot of times the Indian kids, depending on the size of the face, you can decide which suture size to use. So I've done markings at the limbus, medial and lateral. I've made a marking at the frontalis, which is 1 centimeter, about 8 to 10 millimeters above the brow. And this is approximately just to see where I would like the position of the eyelid. And now about 4 millimeters above the lid margin, I am making a mark at the medial and the lateral limbus. The reason you're doing it about 3 to 4 millimeters is to avoid the marginal arcade and also to prevent an eversion. The closer you go very close to the margin, you'll get an absolute outward turning. This is a 4-0 Mersilk to take a traction stitch. The frontalis incision is incised using an 11 number blade very gently. You don't want to cut the frontalis as the muscles, the tissues are very thin. And a prefrontalis pocket is made, which we'll come to later, going about 1 to 2 centimeters above. It's better to just use, tamponade instead of cauterizing it, because the frontalis is actually quite thin in children. So you don't want to actually cauterize it too much. In this girl, instead of, though she was 2, I decided to use a 4-0 Ethibond. So the 4-0 ethibond, you can use it directly from the needle to either start with the eyelid end, but I prefer to start from the frontalis end. So you cut the needle and you mount it on a free needle, which is a cutting needle. Preferably, you can use anywhere between 16 and 18, depending also on the size that you're comfortable with and works in your hand. Passing it through the frontalis incision vertically, going subfrontalis, suborbicularis, preseptal, and coming out epitarsal. You gently pull it out. And similarly, then you take the eyelid stitch, which is an epitarsal in the epitarsal plane. You don't really need to make a cut here because just the needle tip itself away from the suture. So what you do is you pull the suture away from the point you're entering so as not to cut the suture with your needle tip, as you will see next. So you can see, yeah, someone is retracting the suture, so I don't cut it with the needle tip. And then you go in a reverse fashion along the similar planes. Preseptal, suborbicularis, prefront. And then you will feel a resistance when you're going through frontalis. If you don't, that means you've just slipped through and your eyelid will not get elevated. So I'm coming out, trying to be in the center. And then you adjust it. So depending on the medial and the lateral end of the suture, you can actually adjust, as you can see here, the medial and the lateral part of the eyelid. Then you knot it. So I do about 6 to 8 knots, so the knot becomes thick and does not slip. Often people sometimes anchor the knot with 6-0 vicryl, but if you've taken a good bite through the frontalis, you will find that once you've positioned your suture, you no longer feel the need to have to anchor it because it will hold place. So after this, the ends, usually if you cut them and tuck them, you often find that there's suture granulomas. So what we do is in the pocket that you've created, you pull out the suture, both the ends as is seen here, and then you cut them. So what happens is they are at a stretch, they're flat, they're below the subcutaneous tissue, and they prevent formation of suture granulomas. And this is a little trick which I learned in my fellowship, and it really made a big difference. And a frost suture is taken. So this was the patient post-operatively. Coming from the eyelid ptosis to using the eyelid crease to go into the orbit. This is a medial dermoid. This is a short video to show the eyelid crease approach for a medial dermoid. So a lot of us are comfortable with the lateral end, but this is to show that for medial dermoid. So the scan which I showed is not of this patient. She had a much smaller frontoethmoid dermoid, but this is to show that once you've done eyelid crease incision and you've done a suborbicularis dissection, the eyelid, even in a child, is malleable enough to reach up and get the edge of the dermoid. So using blunt dissection and an RF cautery, you can dissect gently around it. And you can see where the original marking of the lesion is and how we've retracted the eyelid. So a complete dissection is done 360 degrees. The tissues are dissected. Oh, sorry. That was a slip up. So I'll just quickly show this. So using a cryo probe, you can remove it and then just suture the eyelid, either in, if you feel that there's a little tension, you can just even suture the eyelid or suture the orbicularis with 6-0 vicryl and the skin. So from there, you go to an orbital. This is a classical orbital floor fracture. So this is an orbital floor fracture repair. So an inferior rectus suture is taken. So this is a force duction test, which was done on table prior. Then an inferior rectus suture is taken. Then using So I prefer to do, I think most of us prefer to do inferior fornisal incisions because they are hidden. They do not cause any major scars. And plus you can reach not just the floor, even you can reach the medial and the lateral part if you need to assess the fractures there. So subconjunctival dissection is done. Then a post-septal dissection is done to reach the orbital floor on the orbital rim, which is 2 millimeters away. And the periosteum is reflected along with the periorbita, and the tissues are dissected so that you can reach the orbital floor fracture. As you can see here, we are retracting it using a lid guard, and you can see the beginning of the fracture there. As you can see, the fat which is herniated, and that's the fracture which you can see, and we are gently teasing out with a blunt forceps, and that is the extent of the floor fracture. So you've cleared out all the herniated tissues. And I prefer to use porous polyethylene. So porous polyethylene comes as like this, like a barrier sheet, which is coated smooth on one side, which goes on the orbital surface, has a truncated appearance. So you cut it to the shape you want and it molds. And you size it and place it. And once that is done, you suture the conjunctiva. So to summarize, you should know your anatomy because that's really what makes your surgical success. Plan the surgery. Every surgery will have a certain success in your own hands, and master a technique and then keep evolving that so as to have lesser steps and better results. Thank you.
Thank you so much, ma'am. It was very well in time, ma'am. Thanks a lot for doing that. Grover sir, we would like to take Raksharao ma'am's talk in the end.
Yes, that will be good. Sure.
Right. So may we go ahead with our next speaker, sir?
Yeah.
So our next speaker is Dr. Jitendra Jethani. Would you like to share your screen, sir? Dr. Jitendra Jethani is a board-certified pediatric ophthalmologist, and he is the director of Baroda Children Eye Care and Squint Clinic. He has 55 peer-reviewed publications and more than 200 presentations on pediatric ophthalmology and strabismus. Over to you, sir.
Okay. Am I audible?
Yes, sir, you're audible. Please share your screen.
Yeah, I will just share my screen. Thank you. So,
and we request all the speakers to please stick to the timeline because we are kind of running short on time here.
Sure thing.
Thank you.
So, thank you. First of all, I would like to thank Dr. Honavar and AIOS for giving me the opportunity to speak on strabismus evaluation. We will, to begin with, we will establish the goals of examination. And there are majorly it can be divided into four, so that it makes it easier for us. First and foremost is to establish the presence and type of strabismus, whether there is any pseudo strabismus or any latent deviation, and whether it is iso, exo, horizontal, vertical deviation, whether there is any presence or of amblyopia or not, whether what is exactly the amount of deviation for management, and to assess the binocular sensory status. But before we talk about strabismus, I think this is very, very important when it comes to pediatric patients, and we will have some quick slides on visual acuity. I won't be taking it in detail, but I always think that this forms the basis of strabismus evaluation, and I always like to take a couple of slides on this. So in children, there are different ways and methods to measure visual acuity. We should be aware of what are the visual milestones when we are examining kids. By 4 to 8 weeks, the fixation is very well developed. And by 3 months, they start reaching out to interesting objects. Obviously, this is a normal developmental milestones of the kids. And by 6 months, they start having the stereopsis is there, and if we test it on VEP, they will have 6/6 vision. And by 12 months, they will start scribbling with crayons. By 5 years, stereopsis is very well developed. This is just a small slide that, very small newborn infants also can see and can imitate the expressions. This is just a small division of detection visual acuity, resolution visual acuity, and recognition visual acuity. So our Snellen's comes under recognition visual acuity, but then there are preferential forced looking tests, Catford drum, and OK and nystagmus drums. Another pillar or another very important aspect of, before we go to talking about strabismus evaluation, is cycloplegic retinoscopy. An accurate refraction is very, very important because this controls your strabismus evaluation. So accommodation has to be controlled before you start going towards motor evaluation of strabismus. Motor evaluation of strabismus would be broadly divided into measuring the amount of deviation. Before you measure it, you have to qualitatively tell whether it is ESO, EXO. You have to do a cover test. And I think cover test is not just the first step, but in fact, cover test takes care of almost everything. So cover test is an umbrella test under which you have cover test, cover uncover test, alternate cover test, prism cover test, and corneal reflection test. So the types of deviation can be what exactly the cover test will do. It will tell you whether it is ESO or EXO. So you do a cover test, and when you cover the eye, if the eye comes from out to in, it is exotropia, and if it comes from in to out, it is esotropia. Whether the deviation is manifest or it is latent, whether it is unilateral, whether the fixation is only, whether there is a master eye, and whether there is a unilateral strabismus. Cover test tells you about amount of deviation, fixation pattern, whether there is any presence or absence of latent nystagmus, whether there is incommittent deviation, which means that fixing right eye, fixing left eye, if there is any incommittence, whether there is any presence or absence of amblyopia, and if there is a dissociated deviation. That also cover test will tell you. What are the tools needed for cover test? You need a fixation target. Don't do it with a torchlight because you need a fix. As I said, you need to control accommodation. You need to know whether the child is accommodating or the person is accommodating a lot or not. So you need a fixation target, and you should control accommodation by giving adequate glass power, whatever their glass power is. So you have to do a cycloplegic retinoscopy before you start managing strabismus. You need an occluder. You can use palm of the hand, but not fingers, because light and target can be seen through it. Torchlight only for Hirschberg corneal reflex test, not really for cover test, and prisms to measure the amount of deviation. Corneal reflex test is like inspection. And so 1 millimeter of each millimeter of eccentricity would point to around an angle of 7 degrees. And if the reflex is at the pupil, you can say that it is around 15 to 20 degrees. So this is just a brief way of finding out whether it is ESO or EXO. It may be pseudo strabismus in corneal reflection test. And so the gold standard comes back to cover test. The first part of cover test is cover test, which means that you have to cover the seemingly fixating eye, which means that when you feel that if it is the left eye which is fixing, you have to cover the fixating eye. Because if you cover the non-fixing eye, you don't get any information. You cover the seemingly fixating eye and see the response of non-fixating eye. If it comes from out to in, it is exotropia. If it comes from in to out, which means that if the eye is nasally placed and if it moves temporally, then it is esotropia. If it moves from down to up, it is hypo. And if it moves from up to down, it is hypertropia, basic terms. The next step obviously is to uncover the eye. Since you have covered the seemingly fixating eye, the non-fixating eye will either take up the fixation. It has to, because there is no other eye to fixate. So it will take up the fixation, or if it is severely amblyopic, then it will not clearly take up the fixation. You can see whether there is a latent nystagmus or not. And so the next step is to uncover that eye. Once you uncover that eye, either the other eye which had taken up the fixation would hold the fixation. In that particular case, you will call it alternate deviation, alternate ESO, alternate EXO, alternate hyper. But it would be alternate because both the eyes are able to take up the fixation. So patient or child is able to alternate. This is completely different from alternate cover test. If you do an alternate cover test, never do that. What happens is in the OPD, we want to do it quickly, and normally in post-graduation, patient comes, we do an alternate cover test. That would always tell you that there is an alternate deviation because you have alternatively covered the eye. So there is no other way of finding out whether there is a unilateral deviation or not, but by doing a cover-uncover test. So the fixing eye may hold the fixation or it may lose the fixation. If it loses the fixation, then it is unilateral deviation. The seemingly fixating eye again takes up the fixation. Sometimes the eye may hold the fixation but may lose it after a blink or a movement. This is alternate deviation with one eye being dominant. What is alternate cover test? Alternate cover test is when none of the eyes are fixing and you want to manifest the latent deviation, which means that there is a phoria. You want to break the fusion, so you don't want at any point of time both the eyes to remain open. So you do an alternate cover test, and then you want to make sure that the latent deviation becomes manifest. So this test will tell us about phoric deviation. Now this is just a small video, but we will move forward. I think there is a okay, video is not working. It's okay. So we move on to the amount of deviation. How do you measure the amount of deviation? You measure amount of deviation by keeping appropriate prisms. And what is the direction in which you keep? If there is esotropia, you will keep it base out. So you will remember it like apex towards the deviation, which means that apex of the prism will be towards the deviation. So if it is eso, the apex will be on the nasal side. But when you write it in your book or in your case paper, you will write on the basis of base. So if apex is towards the deviation, if apex is nasal, the base will be towards the temporal side. Out means towards the ear and in means towards the center part of the body. So it is base in, base out. So for ESO, you will use a base out prism, and it is recorded in prism diopters. Now this is just a small test to show a Krimsky test in a partially accommodative case. This is a child. The mother is holding his ear. You can see that there is a left esotropia. Once you give him glasses, we have covered his right eye, the seemingly fixating eye. The left eye takes up the fixation. The moment we leave it, the left eye goes back, which means that it is a unilateral deviation, left eye esotropia. The child had plus 6.5 glasses, and so we give the glasses, again do the test. The left eye, you can see that he is not able to see clearly and is sort of searching. Left eye has poor vision, and so cover test also tells you that left eye is not able to hold fixation. Left eye is indeed amblyopic. Then you move on to put prisms. Here you would use apex towards the deviation. This is modified Krimsky's test, where we are putting apex towards the deviation prisms in front of the fixing eye, and we try to see that the light should try to come that. So that would be apex towards the deviation. So next we will see ocular movements. Now ocular movements can be broadly divided into ductions, versions, and vergences. So ductions, you can see that this is where you can see the ductions. You can see that the patient is able to move. You can see that there is a small infraoblique overreaction here. When you cover one of the eyes, it is duction. When you see with both eyes together, it is vergence. And when you do a disconjugate movement, it is convergence or divergence. We will just move. Okay, this was a small device which we made to measure ductions, and this is to measure ocular movements. And this is the normative data for abduction, adduction, elevation, and depression. So this is just to tell you about measuring ductions. Okay. Now we move on to the second part of strabismus evaluation, and that is evaluation of the sensory status. Now, what is binocular single vision? It has been grossly divided into three parts. This was divided way back in 50s by Wirth. Claude Wirth was the guy who divided this. Now, you know, this a very important point here we have to understand is that these divisions are made by us for our understanding, for our reproduction, that we can reproduce the same thing, like simultaneous macular perception. If I am seeing on a synaptophore, somebody else should be able to reproduce the same thing. Nature doesn't work like that. There is a possibility that on one test you will see fusion, And if there is another test which is more dissociative, you may see that the patient is not able to fuse. However, the prerequisite for these things are that images should be falling on corresponding retina and they should be almost of the same size and shape. Only then they can overlap. Simultaneous macular perception is between fovea and the parafoveal area. Fusion is sensory and motor. So motor is when the ocular movement takes place to fuse an object. Otherwise, you will see those things as double or you will have confusion. And stereoacuity is when the image is still in the Panam's area, but not really on the same horopter. So the difference between fusion and stereoacuity is that in fusion, corresponding retinal elements are stimulated and motor system is required. Here you don't need a motor system and it is a three-dimensional thing. Fusion, it will function equally well for all fixation distances, and fusion can occur without stereoacuity. But without fusion, you may not have stereoacuity. And stereopsis occurs only in horizontal disparity because horopters are horizontal. You cannot have vertical stereoacuity because both the eyes are horizontally separated. They are not vertically separated. So a trick question is whether vertical stereopsis is there. You cannot have it because the image will still be in the same horopter if it is a vertical separation. This is what I was saying. When you have an image on fovea and on a point which is not on fovea, you may either have confusion or diplopia. And to adapt to that, you have motor fusion to try to bring it back to the center. Then there are So then another question normally is about what is suppression. Now suppression is active central inhibition to avoid confusing images which are originating from the retina of the deviated eye. Because if you are seeing two images, one of the images has to be either suppressed or removed so that you don't have double vision. This can occur only when the visual system is still immature. And you may have another adaptation which is abnormal retinal correspondence, which is of two types, harmonious. Yeah. So these are some of the tests to see, to look for these sensory status. Red glass filter test. Here, basically, we are dissociating the two eyes with the help of red filter. Worth4 dot test mainly tells us whether the person is able to see binocularly or not. So it will basically give you an idea whether binocular vision grossly is present or not. The right eye will have red glass, the left eye will have green glass, and the right eye will see 2 dots, left eye will see 3 dots. And this is how you will have a Worth4 dot test. And no, I don't think we have much time for that video. And then you have other tests like Bagolini's glass, a wonderful test. This is the normal response, and these are some of the tests for stereoacuity. I think just those stereoacuity tests you should see. This is a tetanus fly test, TNO test, and Lang's test, Frisbee test, and this is a gross 2-pencil test, another wonderful test which you should do for stereoacuity. So thank you so much. Thank you so much. I'm sorry that I exceeded the time.
Thank you so much, Dr. Jitendra, for being such a wonderful speaker for the session. Ladies and gentlemen, we also have our 2 chairpersons in the session right now. That is Dr. Pradeep Sharma, and the second one is Dr. Kekunia. So I welcome both of the chairpersons in the session, and over to the chairpersons. You can just welcome all our next speakers in the session. Thank you.
So it's mute, sir, Pradeep, sir.
Yeah, I request the chairpersons also to please unmute themselves, so you would be audible to our audience.
Thank you, Tanvi and Rolika, for having me. I'm sorry that I had to join a little late coming from the clinic. I got a little delayed.
No worries.
So I don't know exactly what, I just saw Dr. Jitendra Jithani giving a wonderful presentation on the eye examination. I'm not aware what was done prior to that. I presume it was
Oculoplasty.
It's over, no? Okay.
Not over. The one speaker left for you to listen to.
Okay. And right now we had the first speaker for the eye examination, the squint examination.
Yes.
So we can carry on with the second talk then, because I think we may be running behind time then.
Okay, sure, sir. So we will move on to our next
Is Raksha ready now?
So there is some problem with Raksha ma'am's internet. So unfortunately, either she will not be able to present, or in the end, if we have time, she'll be able to present.
Okay.
Okay, so we move on to our next speaker, Dr. Swati. Ma'am, please go ahead and share your screen. So her topic is strabismus X-files, and ma'am is an associate professor at RP Center, and her specialty includes strabismus and neuro-ophthalmology. We are happy to hear from you, ma'am.
Good afternoon, everyone. Good afternoon, Dr. Pradeep Sharma sir, Dr. Grover sir. And before I begin, I would like to thank AIS and Dr. Honavar for making me part of this program, EyeShala. So I would straight away begin with the cases presentation. Dr. Jethani has actually made my things simple. Are my slides visible now?
Yes, yes.
Yes, ma'am. You can make it a slideshow, ma'am. Yeah, the top button, ma'am. Down, bottom right, the slideshow button, ma'am.
Actually not visible, I think because of...
Yeah, your cursor may not be visible. So
Yeah.
yeah, that's right.
Perfect.
Yes, ma'am.
Yes. So I would just take you through 3 cases which are usually part of the short or spot cases in the exam, because this is mainly a program which is directed to postgraduate students. So these are just 3 very short kind of cases which do cause a lot of confusion and anxiety in students. So I've just tried to be more clinically oriented with these cases rather than the management and the surgical part. So this was a first case where a 5-year-old male child presented with the inability to move left eye outwards and inward deviation of the left eye at the same time. His otherwise ocular examination was absolutely normal, with the vision normal 6/6 in both eyes, anterior and fundus examination both normal. But if you look at the ocular movement, you can see that he had this small palpebral aperture on the left side, which worsened when he moved his eyes towards the right. That is, on adduction it worsened, and on abduction the palpebral aperture increased. So this is a case where there is a change in palpebral aperture with the limitation of abduction. Now, if you have a case of a limitation of abduction, the 3 main differential that come into mind are 6-nerve palsy, Duane's retraction syndrome, and infantile esotropia with cross fixation. So how do you differentiate these 3? So this is our case where this is the child who has small palpebral aperture and the limitation of abduction. So it can very, very clearly see that there's a retraction of the globe. So that's number 1 differentiate, how you will differentiate it from the 6-nerve palsy. The second important differential is the presence of the deviation. So the amount of deviation in 6-nerve palsy is much more as compared to that you can see in the cases of Duane's retraction syndrome. So even though the limitation is say around -2, in this case, the amount of deviation is not so much. It could be hardly around 15 degrees or maybe even less than that. But in this case, in the case which is shown down, you can see that there is a significant amount of limitation of abduction in the right eye, as well as the amount of deviation is pretty large, which may be as good as more than 60 prisms. So this is one very, very important differential that you have to keep in mind. The other differential that is a very subtle sign, but if observed carefully can be picked up is the size of the palpebral aperture. So because this is a paralytic muscle, the size of the palpebral aperture is more in case of paralytic muscle. While since this is a restrictive squint, the size of palpebral aperture is less. So that's a very soft sign, but yes, can be picked up. The next common mistake what postgraduate students generally do is to examine a case of infantile esotropia with cross fixation, and they find that there is a limitation of abduction, which is actually due to the cross fixation of the for the child. So it's better to do check for the adduction movements after checking for the version movement. So once you cover the fixing eye, look for the abduction. And now in this case that the abduction has become full. So now we clearly know that this probably is a case of Duane's retraction syndrome. The basic pathophysiology of Duane's retraction syndrome is the absence of deficiency of 6th nerve innervation to the lateral rectus muscle. Instead, the lateral rectus muscle gets innervation from an aberrant branch of 3rd nerve. And that is the reason why when the patient looks in adducted position, both MR and LR are firing simultaneously, which leads to the retraction of the eyeball inside the eye, as well as other clinical features like upshoots and downshoots. So what are the indications of surgery in this case? First indication is to maintain the binocularity if there is a presence of squint in primary position. The second indication could be a head posture, to correct the head posture. The other important indication is the cosmetic, because sometimes these upshoots, the retractions are very cosmetically very troublesome. So you have to correct this and give whatever best possible cosmesis to the patient. So there are numerous surgeries that can be done, but the idea that has to be kept in mind whenever one is operating a case of DRS is that we have to weaken the LR, or because it is receiving the aberrant regeneration from the third nerve, but not strengthen it. So there is no indication for strengthening the LR in this case, because it may otherwise worsen the retraction. So coming to case 2, so this was a 16-year-old male who complained of upward deviation of left eye with the presence of right head tilt. Now these are the ocular movements of this patient. You can see that the left eye is the hypertropic eye, which on the dextroversion is there is an inferior oblique overaction. So you know that this probably is an inferior oblique overaction, or you have to differentiate whether there is a superior oblique underaction. So whenever you have these kind of vertical deviations, the best test to differentiate the various muscle paralysis is to do a Parkes 3 test step. One has to note that Parkes 3-step test is specifically for cyclovertical deviation and is positive only during the acute stages. Once there is a spread of comitance, maybe this test may not be so specific. So the first step is to look at the primary deviation, primary gaze, where you have to know which eye is hypertropic. So in this case, the left eye is hypertropic, which suggests that probably there is either a right superior rectus or right inferior oblique underaction, or there is left superior oblique or left inferior rectus underaction. The next step is to look at the secondary gazes, where you will find that the hypertropia is now increasing on the dextroversion. So out of 2 muscles, now we have zeroed down to 4 muscles. Now we have zeroed down to 2 muscles. So because the hypertropia is increasing in dextroversion, we have now zeroed down to 2 muscles which act during this gaze are right superior rectus and left superior oblique. So after you have zeroed down to 2 muscles, the next step is to do a head tilt test. And you will notice that on the left head tilt, the amount of hypertropia is increasing, while on the right head tilt, it is same or less than in primary position. So this is a sign that tells us that this is this left superior oblique which is underacting because the superior rectus of the left eye has to overact to compensate for the intorsion due to the left superior oblique palsy. So this is a clear-cut case of left superior oblique palsy, and we should also look for the torsion in such cases, where in cases of a normal case, you can have the fovea, which is placed normally between the line passing from the inferior pole of the disc and the line passing from the middle of the disc. While in presence of intorsion, you can have fovea which is displaced upwards and upwards to the line that passes from the middle of the disc. So always check for the torsion. Why is it important to check for the torsion? Is that we should not miss the bilateral superior oblique palsy, which is seen especially after the head trauma. So in these cases, the vertical deviation is not so much. There is minimal vertical deviation, and in either gazes the hypertropia increases. But what is characteristic is that head tilt is positive on both the sides, and the amount of torsion is much more than 10 degrees. So you can classify superior oblique palsies. It has been classified by NAPS as class 1, where the maximum deviation is in the direction of inferior oblique. So you have to weaken the inferior oblique. The second type is where the maximum amount of deviation is there in the action of the superior oblique. So one has to strengthen the superior oblique. The third type, where the maximum amount of deviation is on the contralateral side. So you may have to work on both the muscle, the superior oblique as well as inferior oblique. The fourth type where it is also there in the down gaze as well as on the contralateral side. So one may have to either recess the superior rectus of the same eye or recess the inferior rectus of the other eye. The type 5 where the deviation is exclusively in down gaze, where we may have to strengthen the superior oblique of the same eye as well as recess the superior rectus of the same eye, or we have to weaken the inferior rectus of the contralateral eye. The type 6, as I have just discussed, is bilateral superior oblique palsy and seen in the cases of trauma where the torsion is more than 15 degrees. 7 is because of the is a Brown syndrome where you have trauma at the trochlear level. So the deviation, so the presentation is both as Brown syndrome as well as superior oblique palsy. So this is my last case, the third case, where you can see that this was a 26-year-old male who complained of the downward deviation of the right eye. Again, it's a vertical deviation, and you can again look that this vertical deviation is now increasing on the levo version with a downshoot of the right eye. Also notice that there is a limitation of elevation in adduction on the levo version. So this is clearly a case where one has to differentiate whether this is a case of inferior oblique palsy or a Brown syndrome. So in inferior oblique palsy, there is a pattern exotropia because of the superior oblique overaction, while as in Brown syndrome, you may have a divergence in upgaze. Nonetheless, the confirmatory test for Brown syndrome is the FDT, where you want to depress the globe inside the eye, adduct it, and then try to elevate it. So any amount of resistance or any amount of limitation in elevating the eye is suggestive of positive FDT. So the other differential could be monocular elevation deficiency or blowout fracture. So in both the cases, you will have a limitation of elevation both in adduction as well as in abduction, or which may be even worse in abduction as comparison to Brown syndrome, where the elevation is limited more in adduction. So that's the important differential one has to keep in mind. The main cause of the Brown syndrome is various problems at the level of trochlea or at the level of tendon or at the level of telescoping of the tendon from the sheath. So you may have a short anterior tendon sheath. You may have an inelastic tendon. The basic thing that whenever the superior oblique acts, the tendon comes out of its sheath and then it causes, it allows the eye to move down. But if the tendon is short or inelastic, it may not be able to come out and eye may not be able to move. So there may be a problem with the trochlear complex itself. The entry may be small. There may be some kind of restriction. It may be seen in acquired cases also. Whenever there is inflammation or fibrosis at the level of trochlea, you may have the acquired Brown syndrome. The other cause of acquired Brown syndrome could be surgical iatrogenic, where it is secondary to the tucking of the superior oblique muscle or due to scleral buckling or glaucoma valve surgery. So the main surgical options are weakening of superior oblique, which is really unpredictable and incomplete. It doesn't work very properly. So the best surgical option is the lengthening of the superior oblique tendon, which can either be done through silicone band expander or non-absorbable suture, which can be put in between the tendon as secant suture, or which can be put at the insertion as loop tenotomy. I think with that, I'll finish my case presentation. Thank you.
I think, Dr. Swati, you have done a wonderful job in your limited time, and you have still time to spare, maybe 1.5 minutes. So I think you have covered three interesting cases which are for the examinees to differentiate. And I think you have highlighted the points of differentiation. First of all, in the case of the ESO-DRS, to differentiate from sixth nerve palsy by seeing the ocular deviation difference between the limitation of movement. Secondly, the force duction test and the narrowing of the palpebral aperture. So these are three classical points which will always clarify a case of Duane's retraction, ESO type, from a sixth nerve palsy. You also mentioned about differentiating across fixator infantile esotropia, and that also can be checked by just patching one eye and seeing that the limitation of movement of abduction improves. The second case also highlighted the difference of superior palsy from the primary inferior oblique overactions. And I think you raised the point, which again is a very important step for the examinees to look for a head tilt test, the Parkes head tilt test, and you showed that how it can be easily differentiated. And the third case of Brown syndrome, which many a times can be a sort of problem for many examinees. So you have again picked up a nice case to differentiate it from an inferior oblique palsy, which will have an A pattern, whereas Brown's classically has a divergence in upgaze, limitation of elevation in adduction, whereas the limitation of elevation in abduction is not there. So there is full elevation in abduction and only limitation in adduction is there. And also differentiated from the MEDs and the blowout fractures. So I think you have made your point very clear. And so I think we can move on to the third speaker, who is going to tell us about the management of these cases, the dosing and the surgical steps. And we have none other than Dr. Manjula Jayakumar from Chennai to tell us about this. It will be interesting. So for all of you to listen to her. So Dr. Manjula Jayakumar, please.
Thank you, sir. I'll share my screen. Just give me a moment.
So Dr. Manjula Jayakumar, ma'am is a pediatric ophthalmologist with over 20 years of experience. She's been trained at Shankara Nethralaya, Chennai. And currently she's a senior consultant and in charge of pediatric ophthalmology at Dr. Agarwal's Eye Hospital, Chennai. And she has several publications in both international and national journals.
Thank you very much for the introduction, Rolika. I'm going to talk on strabismus surgeries, which is actually a very complex topic, but I would like to make it as simple and as interesting as possible for the postgraduate students. So before we embark on strabismus surgery, we need to look at certain other requirements. You need to treat the refractive error, correct the amblyopia if it is present, do orthoptic exercises if possible, and then embark on your surgery. The goals of the surgery has to be clearly explained to the patient, and the importance of follow-up also has to be emphasized, especially if it's a small child. Now, the indication for strabismus surgery is basically to provide alignment. Alignment means both eyes will have the same visual direction and they look at the object of regard. And with alignment, we can also improve the binocular single vision, which means you're providing stereopsis to the patient. You can also improve extraocular motility in certain cases and increase the field of vision. Now, this is three cases I would like to illustrate. This is a small child with infantile esotropia. This child is perfectly aligned, but the sensory result is a microtropia with peripheral fusion and cross stereopsis. This young lady with IDS had good pre-existing stereo vision. So after surgery, apart from alignment, we are retaining the stereo vision and central fusion. Now, this particular child had an MED, and as you can see, there is an elevation deficit. So post-surgery, we are also improving the extraocular motility. The elevation is improved. Apart from giving a good central alignment, we are also increasing the motility and field of vision. So these would be the gross indication of surgery. Before you embark on surgery, look at the position of the patient. This is very important. The neck has to be extended, and then only you have a good exposure of both eyes. And you need to have a fine set of strabismus instruments. But I would emphasize on the various beautiful hooks that is available for the strabismus surgeon. This is the smallest one is the Stevens stenotomy hook. Then you have the Von Graffi smooth hook, the Chavez's hook, the Helveston hook, and the Green's hook. And of course, there is another hook called also as the Jameson's hook. So you need to have this entire armamentarium of instruments with you. And also, I would like to teach the beginners on certain anatomical landmarks. The limbus is one important landmark. Limbus is the point where you have the fusion of the conjunctiva, the Tenon's capsule, and the intermuscular septum. So when you make a limbal incision, what happens is you directly enter into the subtenon space, and it's very easy to hook the muscle. The other thing you have to pay heed to is these two pads of fat, the extraconal pads of fat at the fornices. And you can look at the superficial conjunctival vessels and the deeper anterior ciliary vessels. Now, the next particular slide is the fornix incision. Now, when you do a fornic incision, you have to open up the conjunctiva separately. You have to open up the Tenon's capsule separately, and then you can place your muzzle on your Jameson's hook. And this tissue which you see here, where the muzzle hook is indenting, is the intermuscular septum. And you can see these beautiful anterior ciliary vessels, which are causing for the muzzle and going anterior to the muzzle insertion. Now, the dosing of the surgery, the medial rectus muzzle anywhere between 3 to 7 mm, lateral rectus is a little larger, 4 to 10 mm. The superior and inferior rectus is 3 to 6 mm. And you don't do more dosage for this vertical recti because you know they are attached to the lid retractors and they can produce changes on your lid position. But there are, of course, exceptions, especially when you operate on a patient with DVD or tight muzzles. And R&R always will have an augmented effect. It's about 25 to 30% more augmentation. And when you operate on smaller or pediatric eyes, your dosages have to be also lesser. Now, adjustable versus fixed, all beginners should start with fixed sutures. Unpredictable results go for adjustable sutures, and they are seen in paretic muzzles, restrictive strabismus, myopathies, and resurgence. Weakening procedures on the muzzles are recessions and the Faden operation. Strengthening, of course, is resection, advancement, and plication. The first surgery which I'm going to show you is an adjustable surgery on a limbal flap. This is the noose. So you're creating a limbal flap, which is easy to create. You hook the muzzle. You dissect it free of its attachment. It has to be smooth and shiny in its muzzle capsule as seen here. You're cutting the intermuscular septum. There is a 3-point fixation of the muzzle. The first central fixation bite and the 2 locking bites at either edges. So the first surgery I'll show you in detail. The rest I will just show you the important parts of the surgery. There's a lot of surgical videos. So this is the 3-point fixation, and at the edges you take locking bites. You disinsert the muzzle. After disinsertion, you're going to cauterize the stump. Gentle cautery, there's no need to do a heavy cautery. And then since this is an adjustable noose suture, I mark the center of the muzzle stump and I will take the crossword technique. So you will be taking 2 blights in the sclera very close to each other in a crossword fashion. The muzzle is going to hang behind. So this is called as the hang back. You create a noose on this suture. So you create a noose here, and this noose is adjustable. You can move this noose up and down. Suppose you want to recess more post-operatively, you can move the noose forward or backwards. A noose is created. And you can see just in a moment how it can be moved up and down. See, you can, and then I will hang the muzzle. See, I'm measuring the amount of recession. So I will be hanging the muzzle backwards. And then I will close up the limbal flap. If you're afraid of creep, you can place belt sutures close to the muzzle here. Superficial belt sutures. Okay. So then the limbal flap will be closed up. So I'm not showing that. I'll move to the next video. The next is plication. The first video was a recession. Recession is you make the muzzle lax, so you weaken the muzzle. Plication, you make the muzzle taut. I will go a little forward. Yeah. So in this plication, what I want to show is the muzzle is formed like a hump. So I'll go here. See, after taking these bites, I'll go a little faster. Yeah. So you go anterior to this thing, insertion of the muzzle, and you will hump it. Now, I don't do this. I do Dr. Sharma's technique, which is the modified plication or reinforced plication, because I don't want this a little unsightly hump to be formed. So I go to the next video. Again, I put it on noose adjustable. I do adjustables all the time. So you can do the fixed suture also. This is the reinforced plication. I'll go to the part where this is a small plication. So again, you will, the amount of measurement, you place the suture on the muzzle. So amount of time, I just go a little forward, yeah. So you take the bites anterior to the insertion of the muzzle and you come back into the muzzle and it will fold over. It will neatly fold over. See, the muzzle is folded. And now I put the adjustable noose here. So even the resected muscles are put on a noose. The recessed muscle is also put on a noose. I don't adjust, but I always do it as a methodology which I am tuned to doing, so that if I want to adjust, I can always adjust. Now, this is the reinforced plication. Now I'm showing you the fornix incision. The fornix incision is done at the infratemporal fornix. Let me show you. I've disinserted the muzzle. It's a little cumbersome because, and then this is almost like a fixed suture, but what I'm doing is I'm placing it on a bow tie. Now, just to show you how a bow tie is done. But you can do a square knot and you can fix it also. No harm. Once this bow tie is done, you'll close up the incision. So this needs a little maneuverability. I'm not going into the detail of the fornix surgery. And then you close up. So on the other side, we will show the resection. So on the other side, I mark this amount of resection. You do a 3-point here. Okay, this is again a fornix incision. So once you do that, I will disinsert the muzzle. Because I'm showing all the surgeries, I'm a little bit fast forwarding, otherwise the time won't be enough, I'm sure about it. I will disinsert the muzzle. This is the amount of resection where I'll cut off this portion of the muzzle. Thereby, you're shortening the muzzle and making the muzzle taut. Now, at the stump, I will be taking the bites and I'll be coming back into the muzzle. Okay, so I'll be coming back into the muzzle. And then I will be tethering the muzzle at the insertion. So the excess of muzzle stump will be now cut. So once I will come on either end, I will tie it down. Again, this is done on a noose because if you want to recess that resected muzzle a little bit post-operatively, if you want to adjust, the noose will help you. And then I will cut off the stump. So this is how I will do. Then I will close the flap. I'll go on to the next surgery, which is fade-in operation. Fade-in is when you want to increase your recession effect, you will do a posterior fixation. This is my technique, which is published in the IGO. After doing the 3-point fixation with the non-absorbable suture, you take 2 bites, one at the recession side and one at the posterior fixation side. Now I have done about 7 mm of recession and 12 mm is the posterior fixation. I'll come back into the muzzle at the recession side. Then I will disinsert the muzzle. I'm disinserting the muzzle. And you can see that I have, I'm tightening the posterior fixation suture side. And you can see that it is recessed by 7 mm and the posterior fixation thing is around 12 mm. So you increase the arc of contact, you reduce the momentum, thereby there is more recession effect and decrease action of muzzle in the field of action of the muzzle. So we'll go to the last thing, which is inferior oblique recession. So again, I'm going to show you. Now I'll start here. I will reduce my, this is got this thing. This oblique muscle close to the larger rectus. I will reduce this voice. With this, I have, since it's a very lax tendon, I've removed part of the tendon before placing it at the inferior rectus incision. You can do that because you want to augment the weakening effect further. Otherwise, you can place the entire stump also at that point. So I mark it at the inferior rectus and then I will place it. This is again placed on the noose. And then I go forward and I do the lateral rectus recession on this patient. Once the recession is over, I will close up the conjunctiva. You can just see how small this site of incision of the muscle is. So finally, I'll be just showing you, I'll be closing up this fornix incision. So the lateral rectus incision is also over. Inferior oblique, anterior transposition and lateral rectus recession is over. Both have been placed on adjustable moves, and I'll be closing up this. So you can see once I've closed up, it's such a small incision. I'll remove the thing and I will show you. When I remove the, see, it is just under the lid. You are operated upon. In case of SO palsy, so the last side, the commonest muscle that you operate upon is your horizontal recti. It corrects your horizontal deviation. It also corrects some amount of small vertical deviation when you shift the muscle up or down. You can correct your A and B patterns by bringing your medial and the lateral recti, the medial recti towards the close end of the pattern and the lateral recti towards the open end of the pattern. Paretic spins can be well corrected by transposing either your horizontal or your vertical recti to other muscles. And inferior oblique procedures are the common oblique muscles that are operated upon. The procedures that we do are recession and anterior transposition. Superior oblique I'm not covered for want of time, but you can always look up videos. Beautiful videos are there in YouTube. Thank you very much for your patient listening, and I hope I could convey the points needed for postgraduate students.
Thank you, Dr. Manjula. You have really covered most of these surgical procedures which are commonly done in a very small time capsule. So really, that's worth congratulations. And you have highlighted the point that we can adjust the muscles and we should be trying to align the eyes. It's not just important to do a surgery, and especially when you're talking of children, it's not just early surgery, but early alignment which makes the difference in restoring binocular vision.
Definitely.
So for that, we have to be either, even if we don't do adjustables, we can restore binocular vision with the help of other procedures like maybe prisms or by adjusting the spherical correction in children if you can't do adjustables. And you have also highlighted that inferior obliques are better recessed and anterior positions rather than doing myectomies, which are non-adjustable and which are like more traumatic procedures and you can't undo it. So wonderfully done. And I think we have now a wonderful topic of basic statistics before we close this part. And that is Dr. Sabyasachi Sen-Gupta, who is a wonderful teacher, to tell us about how we can handle the research methodology in a small time of 15 minutes. Dr. Sabyasachi.
Right.
Thank you, sir. Thank you so much, and very good evening to everyone. And I'll quickly
Please
share my
screen, sir. Yes, sir.
I will do that.
So, Dr. Sabyasachi Sen-Gupta, he is less known as a vitreoretina surgeon and more known as the person who's taught research to all of us. And he is a consultant vitreoretina surgeon at Arvind Eye Hospital, Pondicherry. And he's the founder and director of Sen-Gupta's Research Academy. Thanks a lot, sir. We get to learn a lot from you. And he's also the head of clinical research at Arvind Eye Hospital, and has developed many international associations for the system. Thank you, sir.
Thank you so much. So just a quick correction. So I'm not at Arvind Eye Hospital anymore. I'm into private practice in Mumbai.
Okay.
All right. So
sorry, sir.
No issues. So, I thought I'll start with a little bit of inspiration, and I think it's really important to ask questions. In today's world, unless we ask enough questions, we won't know which is the right one. And I think the questions that you ask define who you are, not the answers you know. So it's a journey of seeking answers to questions, the answers of which are not known. So that has been my inspiration, and I hope some of you residents in the crowd will identify with that. All right. So, I thought, so the mandate given to me was basic biostatistics for residents in this first ever virtual AIOC, and I think it's been conducted very nicely, and congratulations to everyone involved with that. So, I think the roadmap to publish is, you plan and execute the study or your thesis, I mean, basically you plan it and do it, then you have the data with you. So you analyze and then write it up, and finally you review the paper and you submit and you publish. But, so this is a very quick roadmap, but it's not as easy, as this thing shows you. It's important for us to get trained. So I got trained for the first time in research methodology now 12 years back. This was now really 13 years back. So this was at LICO in Madurai. So it's important, like I said, to get trained in basic concepts. And I always tell my students that trying to publish without training is like trying to insert the IOL without an incision. Right. So it's important that you get trained well, and only then can you really do a good job with all of these. There are many courses which are available online. There's a lot of technology which is right in your fingertips. There are many students who are doing this. You can brainstorm with thousands of them. And there are so many people also who are teaching. So choose your teachers wisely. But this is especially relevant for residents and fellows in training, that you get trained with some basics of all these technologies. And a thesis is not really published in India, unfortunately. So there is often this lack of novelty. The design is probably not that great. There is not enough training, like I've already said. There is a bit of apathy or no enthusiasm, and there is lack of interest in faculty in many medical colleges as well. And a lot of us are not aware of so many benefits that you can get by doing good research and publishing. So a lot of thesis really doesn't get published, and whatever is not published gets undone, right? This goes below the iceberg, and you don't know how much there is below that. And a study that we had done showed that a paper which is presented at an AIOC in say 2010, only 12% of them go ahead and get published in major journals or in PubMed index journals over the next 5 years. That's a really small number. In other meetings, larger meetings, that number goes up to 30%, and in international meetings like ARVO or the American Academy, that number really goes to 60%. So I think sort of the onus is on us to go ahead and publish these, which is the final frontier for your thesis or your research. So you need to break barriers, right? You need to probably go a bit faster than you already are, or in the right direction, and you really need to find new ways to to flourish. So like I said, every study goes through phases of the idea, or what is the study topic, then you design the study, you execute and analyze, and then you write and publish. So today we are going to talk a little bit about execution and analysis. And amongst that, what we are going to look at quickly is in the next 10 minutes is about biostatistics. So this is a free ebook which is there on my Facebook page of Sengupta Research Academy, as well as the website. You can actually go ahead and download this. So some basic terminologies. So data really means observations that come from an experiment or research. So any observations that you are doing from patients is nothing but data. And variable really means each set of observations in the data sheet, or in other words, every column of an Excel sheet is nothing but a variable. Right? So we'll be referring to this term variable again and again. So it's important for us to understand, for example, age, gender, vision, BCVA, OCT, thickness, number of injections, or whatever. These are all examples of variables. And we classify variables, as you'll know later on why we classify. But to begin with, we classify variables mainly into two types. On the left, they are either continuous variables or they are categorical variables. So what are these continuous variables? Also called quantitative variables. So this is a variable that can take on many different values. In theory, any value between the lowest and the highest points on the measurable scale, or really it can take any value from 0 to infinity. Okay, and always has a unit to it. For example, age. It can really be from not infinity, but it can be from 1 to say 100 plus as well, and it has unit which is years. BCVA has a unit which is logmar. IOP has unit which is millimeters of mercury. Right? So all these are examples of continuous variables. Now, what are these categorical variables, also called as qualitative variables? These are things which are grouped according to some common property or properties, and the number of members of the group are recorded. Right? So categorical variable can only have a limited number of values. Right? For example, gender can really be male or female. Success can be yes, no. Type of macular hole closure can be type 1 or type 2. So type of CNVM, say classic or occult. Whatever it is you are defining in your own study, but these are examples of categorical variables. And categorical variables really are of three types. One is binomial, that is only two categories, say gender, ordinal. So there are more than 2 categories, but they are in order. So there is, say, complete success, qualified success, or failure, or say mild NPDR, moderate NPDR, severe NPDR, right? So that's an ordinal scale. And third is multinomial. That means there are more than 2 categories, but that there is no order to it. Say there are, the type of injections in a particular study. So quick exercises, height of subretinal fluid in CSR, it's going to be in microns. So this is an example of a continuous variable. Presence or absence of hard exudates in diabetic macular edema. So this is just yes, no, whether there are hard exudates, yes, no. These are examples of categorical variables. So, the last point, the number of days of follow-up of a patient. Again, this is an example of a continuous variable. So once you know, all the variables that you have to try and describe each one of them. So describe one variable at a time. An analogy is, in a cricket team, you describe one player at a time. Okay, so when you're talking about one variable at a time, we call this descriptive statistics. And in one quick shot, continuous variables are described in terms of means with standard deviations or median with interquartile range, and they are shown or depicted, in terms of graphs using outliers. They're in terms of box and whisker plots. And there is a concept of outliers, that means extreme values in a continuous variable, and these are something that you should always try and identify. And best way to show them graphically is box and whisker plots. Now coming to categorical variables, it's relatively simple. It's in terms of proportions, okay? That is percentages, and the best way to show them are in terms of bar diagrams. Coming to, after describing each variable, you want to see how they interplay with each other. So this is nothing but analytic statistics. So again, in a cricket team, how do all players interact with each other and play as a team to get to the final goal, that is to win a match, right? So when you have many variables interacting with each other, that is nothing but analytic statistics. And they're really in 3 forms. One is differences between variables, second is correlations between variables, and third are association between variables, right? So more than one variable are interacting with each other. When you look at differences between variables, the analysis is really based on the outcome variable. So if it's a continuous variable, that is, in terms of mean and standard deviation, they're being described as mean and standard deviation. The test that you use is to differentiate is the student t-test, okay, when it is normally distributed. So if a continuous variable is normally distributed and you're comparing it across 2 groups, say OCT thickness in Avastin group versus Lucentis group, right? So there are only 2 groups here. If the OCT thickness is normally distributed, you would use the student t-test. If it is not normally distributed, you would use the Wilcoxon-Rank sum test, also called as the Mann-Whitney U test. And if there are more than 2 groups, say for example, like 3 injections, right? Say triamcinolone and Avastin and Lucentis. So there are 3 groups here. Now you want to compare OCT thicknesses, say at 6 months or whatever. Now, when there are more than 2 groups, so here, like in this example, there are 3 groups, we usually use the ANOVA, also called the analysis of variance. When you're trying to find differences between categorical variables, that is in terms of proportions, the simple answer is chi-square test. So CAT stands for chi, or categorical is chi-square. And if the numbers of percentages are really small, we use the Fisher exact test. Like I said, differences, correlations and regressions, these are 3 main types of analyses that we use. So I've already told you, what tests are to be used for differences. Correlations are something which are not very commonly used. I haven't put a slide to that, but there are 2 main things which we do is, we present it in terms of correlation coefficients, and they vary from -1 to +1, right? And correlation doesn't give causality, right? So causality is really given by regressions. So again, there are different types of regression analysis that we can do, and it's again based on the outcome measure. If it's a continuous variable, the outcome is a continuous variable, then we use linear regression. The best example of this is many IOL-PAR calculation formulas. Say, for example, the SRK or the SRK-T formula, right? So the outcome is continuous, that is the IOL-PAR. So what we use is linear regression to derive, so that equation can actually give you, so if you know the value of the axial length and the keratometry, you can actually know the value of the IOL-PAR. So these are examples of linear regressions. When the outcome is a categorical, like I've already told you, say a yes or a no, what we use is logistic regression, and the outcomes are in terms of odds ratios. When the outcome measure is in counts data, lots of these are coming up now in terms of, people are wearing these trackers on their hands, and you get counts data in terms of number of steps taken and other things. There we use something called Poisson regression, and the last is survival data. Say for example, outcomes of a trabeculectomy, right? Say our outcomes of, say even mucormycosis nowadays, where, we are talking in terms of survival rates. So what is the death rate or what is the survival rate? There we use something called Cox proportional hazards analysis. So these are the 4 main types of regression analysis that we use, and these are all based on outcome measures. So that's why it's important to understand and differentiate continuous variables from categorical variables, right? This is basically the, in short, a quick overview of how we do all these statistics. So you identify the type of variable, whether it's continuous or categorical, and then you describe each variable in terms of continuous or categorical, and then you look at analysis in terms of differences between variables, correlation between variables, and then association between variables. Lastly, I wanted to quickly give you an overview of sample size and why it is so important. I think it's important to get as close to the truth as we can, right? Because so you can't really go and study 1 lakh patients. Say you're looking at, say, tuberculosis or something like that. You can't go out and study 10 lakh patients or all the patients in the community. You need to have a right sample so that your whatever you find is applicable to all of them. So your sample size has to be just right. It can't be too small and it can't be too large, right? So the adequate sample size, the right sample size, helps us get to the truth, as close to the truth as possible. And what does this influence, right? You might ask, oh, so what if I take too small a sample, or what if I take too large a sample if it's available to me? But then, it influences everything. So a small thing is every p-value in your outcome is going to be influenced by sample size. So sample size really influences a lot of the way we do the study, the way and if it's too large, then you find it hard to complete. If it's too small, then, nothing comes out to be significant, right? So sample size really influences almost everything you do. So this is my website. I hope some of you have taken a look at this. It has some e-learning resources, some free lectures as well. There are lectures offering, overviews on literature review on biostatistics. So, we are talking a little bit about these, but, these are more in detail. And then there are, lectures on manuscript writing and how to deal with rejections. And there's an interesting lecture on reference managers using the Zotero. And there's a larger course, which is a fellowship course. You might want to take a look, and this might interest you more, where this is a thesis guidance course, where it takes you through all this basic knowledge that helps you with protocol design, data visualization, statistical planning, sample size, and then, thesis completion, and then analysis. So, this is something that you might want to take a look at. And there are some other, useful resources on the website. Say there are some blogs which talk about p-values, about regression analysis that I talked about. There are many other blogs that I hope will be useful to some of you. So in generally, this website will help you broaden your research horizons. And I think this is the right time, at least in, residency and your training as fellows, this is the right time to begin. And there are many people already enrolled in these courses, so please take a look at this. This is a Facebook group that my academy runs. It's called Ophthalmic Research and Collaborations in India. There are about 2,500 people. So try and join this group. There is a lot of opportunities to collaborate with people in India. And finally, the take-home message, I think, is train well. Online courses like I've shown you, identify variables, whether they're continuous or categorical, describe variables in terms of mean, median, or proportions, and then do analytic statistics, that is in terms of differences, correlations, and regressions, and finally make the results, which is the part of your thesis or your manuscript. So thank you very much, and I'm happy to take questions if there are any.
Thank you, Sabyasachi. As your name is ambidextrous, you have good control on both clinical as well as the research methodologies. And research methodology, as we all know, is the least taught thing for our residents. Most of the places, there's nothing like research methodology taught even. So I think it's important that people attend to your online thing, which you keep on emailing also for them. And it will be good for them to take. But if there are any specific questions which have come to our moderators, we can take up, unless Dr. Raksha has become available for her talk. Dr.
Thank you, Sabyasachi. Enjoyed your talk. You were inspirational as always. And I'm glad that you taught the postgraduates this vital aspect. I think they have to not just learn it, they have to imbibe it. And I think repeated reminders like these will be very, very useful. Thank you.
Thank you so much.
Yeah, Dr. Rolika, you were saying about Raksha not being available,
yes,
right?
She won't be able to join. So we will take questions and discussion from the chairperson. And as while we are waiting for the next session, chairpersons to join.
Yeah, we have time, I think. 12
Yes,
minutes.
sir.
2.5 minutes.
Yeah, we would start at 5:55 p.m. So we end up on time.
Sure.
Yeah, thank you.
So if there are any questions that you people have got from any of the audience, I think first we should attend that.
So, and audience questions are not there, sir.
Okay, that's. And is Dr. Ramesh on? We can. I don't see him his video. So is Dr. Ramesh Kunia there?
Yes, sir. He's here.
I'm here.
Yeah, Ramesh. Any comments? Yeah.
I request all the doctors if we can have some inter-discussion sessions or any other some queries to come forward or point to be noted. You all can discuss it. The session is yours. Till then, we will move on to the next session till 5:55 p.m. The session is yours. Thank you.
Yeah, Dr. Ramesh, I think we didn't hear from you, so you can. Yeah.
Yeah, one of the thing I don't know about strabismus, there was some discussion going on. I would say that many of the aspects of cover test and everything is covered. But I do see many times residents in the whole diagnostic and therapeutic test, they get lost. So I always classify strabismus in two levels. One is diagnostic, one is therapeutic. Many people give lot of importance to, did I miss that one prism diopters or things like that, and miss the bigger picture. If some patient has abduction limitation, they might miss the adduction limitation. So in my view, a good ocular motility examination is very, very crucial before you go on to cover test and get confused, because cover, uncover, alternate cover, with this, the day of examination, they get confused. I just wanted to say that the most crucial test out of all that is the ocular motility test, which is the most important test. I think even in any of the patients with cataract and all other things, it has to be done. I see many times the ocular motility is missed, and most of the life-threatening disease also is missed. That's one thing I just wanted to add to Jitendra's presentation. Just Pearl, I just wanted to share. Other than that, we had fantastic presentations. I think we will miss the imaging thing. Imaging in strabismus and oculoplasty and neuro-ophthalmology. Raksha wanted to cover. I think it's an important topic.
Yes, we missed her.
So I think what Dr. Ramesh was saying is quite correct, that many a time people only see in this primary position, the deviation is there, and they would miss the other problems. Like there might be, the eyes might be straight, but the moment the person looks in the different gazes, it may be limitation of movement may be there. So an ortho DRS would be missed easily unless you look for the limitation of movements in different directions. So that is an important point to take. And the other thing which I would like to stress upon is looking for the binocular aspects, the binocular vision. So at least do a binocular vision assessment. Maybe if you don't have anything else, Bagolni glasses, if nothing else is there, just a red and green glasses with the TNO test also, if you have, look for the binocular test. If he's seeing 2 circles or 3 circles or more, that will tell you about the binocular aspect. And testing stereopsis in one short way tells you about the full functional aspect of the binocular vision. So if there is any problem with the alignment or with the vision, you can easily pick up with screening just the stereopsis. So Lang's 2 pencil test is something which I find is inexpensive, can be done at any stage, and it's a bedside thing which all residents should be learning and using it. A simple Lang's 2 pencil test horizontally held. Yes, Dr. Grover, would like to add something?
I should keep my mouth shut on strabismus as long as the two of you are speaking. Yeah, but I've enjoyed listening to Squint. As you know, I've always enjoyed listening.
You're always one of the pioneer strabismologists, we know you.
Pioneer students of Squint.
We all are students.
I think oculoplasty and strabismus always go together.
Hand in hand. hand in glove.
Whatever it is. I just have one small mnemonic. I will say LOP, loss of pay. If you don't check in a lid case oculomotility and pupil, and vice versa, in a pupil versus oculomotility and ptosis, you will lose the pay. So I will just put it LOP. LOP is very important. Lid, oculomotility and pupil, they are closely interrelated in
So
many
many
the
associations. Yes,
yeah,
that's true.
whoever is big, because many times somebody is doing a ptosis, they just forget about sometimes pupil. It gives a lot of information. So I think be it Horner syndrome, be it third nerve palsy, be it ocular myasthenia, these are important. I just want the residents to remember LOP. That's very important.
And remember that oculoplastics goes with strabismus.
Yes.
With you, for you, always.
Yes. That's why it's not, 6 extraocular muscles. It's much more than that.
Yeah.
True.
Levator and all the tiny muscles, Mullers, I will add. I would make it 8.
Millers in the upper and Millers in the lower lid.
Yes, yes. Superior Mullers and inferior Mullers.
Yeah.
That's all. I just had 1 or 2 small things to share, Dr. Sharma.
So, anything, Dr. Maya, you'd like to add?
Good evening, sir. Yeah. I attended the last lecture. Actually, I was there in the orbit discussion in the subspecialty session. So it was very informative. I congratulate Dr. Sabyasachi for that, for the PG students as well as for us also, because for the statistics, we have lost the touch for so many years, and now we have to check with our PG students' theses, and I think at this stage I'm planning to join your academy, so hopefully there is a scope for that for us also.
At this
There are
moment,
majority like us.
ask a lot of questions to Maya.
Yeah.
Maya spoke very well. Maya spoke about the various cases, clinical cases that the residents face in their examinations. So what would you say? You are an examiner now, you hold your examinations in your center. If you had the whole array of cases in your center and you were to place 2 cases as long cases from oculoplastics, which one will they be?
So, sir, my favorite case is congenital ptosis, first one. And second one, as I mentioned, is proptosis. I would like to have a thyroid or a lacrimal gland mass for that. So that are my 2 cases.
Proptosis really tests candidates' ability to look at a lot of aspects, include right from history to examination, to be able to analyze, to be able to zero down on certain things. I think it's like an exclusional thing, starting with age, the temporal dynamics, the kind of symptoms, the signs you have. It's really need a very analytical mind to keep excluding things and come to a conclusion. So that really tests. So if I were to choose one, I would choose proptosis.
I think the time's up signal has come. So I think we can all thank the organizers and all the panelists for making this wonderful presentations. Thank you all, and thanks for organizing.
And for giving us the opportunity to meet Pradeep, Ramesh, and all of you.
Yeah, thank you.
Thank
It was
you
nice
so
meeting
much.
you all. Thank you so much.
Thank you
Thank you
everyone
so
for
much, all the
joining.
chairpersons
Thank you,
and
Rolika.
speakers, for such a valuable session. Thank you so much.
Thank you,
Thank you.
Tanvi. Thank you, Rolika.
Yeah.
Bye-bye. Bye.
Bye.